Hello, I'm Professor Fred Saad from the University of Montreal. In this video, I'll explain the significance of intensive triple therapy using Nubeqa. This diagram provides an overview of the disease states in prostate cancer. Recurrent or progressive prostate cancer can be broadly classified into 4 categories based on the presence of metastasis and castration sensitivity. Among them, metastatic castration-sensitive prostate cancer, or mCSPC, has a very poor prognosis. Once it progresses to lethal metastatic castration-resistant prostate cancer, mCRPC. Based on the above, there are 3 main treatment goals for mCSPC. From a prognostic perspective, there are prolongation of overall survival and prolongation of the time to CRPC. In addition, maintaining quality of life is also a key objective. Next, I will present the significance of triplet therapy with Nubeqa. This illustration represents the increasing heterogeneity of the tumor as the disease progresses. A key characteristic of prostate cancer is that it is a heterogeneous tumor. It is believed that such heterogeneity is already present even in the untreated state. Furthermore, tumor heterogeneity increases exponentially with sequential therapies or disease progression. This increasing heterogeneity is thought to be associated with treatment resistance. Given these characteristics of prostate cancer, initiating intensive triplet therapy with agents that have different mechanisms of action at an early stage before heterogeneity expands may be a rational approach to overcoming treatment resistance. Moreover, as in vitro studies have suggested, the presence of cross-resistance between androgen receptor signal inhibitors, ARSI, and docetaxel, their concomitant use may be more rational than the sequential administration. Furthermore, in vitro studies have shown that comprehensive inhibition of AR signaling enhances the sensitivity of prostate cancer cells to taxane-based chemotherapeutic agents. Based on this, the concomitant use of ARSIs and docetaxel at an early stage, before the emergence of aberrant AR signaling, may be a rational approach to enhance the anti-tumor efficacy of docetaxel. From the triplet therapy rationale, the ARASENS trial was conducted. The ARASENS trial was an international, randomized, double-blind, placebo-controlled, Phase 3 study in patients with mCSPC conducted at 301 centers in 23 countries worldwide, including Japan. The study compared a group of ADT plus docetaxel and Nubeqa with a control group of ADT plus docetaxel. The primary endpoint was overall survival, and secondary endpoints included time to CRPC and other items as shown. This is the overall survival result. The hazard ratio was 0.675, indicating that Nubeqa significantly reduced by 32.5% the risk of death, extended OS compared to the placebo group. Overall survival at 48 months was 62.7% in the Nubeqa group and 50.4% in the placebo group. Furthermore, next are the results for time to PSA progression. The time to PSA progression was not reached in the Nubeqa group, while in the placebo group the median was 22.4 months with a hazard ratio of 0.26, indicating that Nubeqa group significantly extended the time to PSA progression. In a subgroup analysis by tumor volume based on the CHARTED trial, both high and low tumor volume patients showed a similar benefit to the overall population. Next, let's look at the results of the ARASENS trial based on the rate at which PSA levels were reduced to below the undetectable PSA. The undetectable PSA rate was 48.7% at 24 weeks and 67.3% overall during the trial period. A subgroup analysis was also conducted, dividing patients into those who achieved the undetectable PSA and those who did not. The time to PSA progression was significantly longer in the group that achieved undetectable PSA. And overall survival was also significantly longer in the group that achieved PSA below 0.2. Here is the safety data. Grade 3-4 adverse events occurred in 66.4% of patients in the Nubeqa group and 63.5% of patients in the placebo group. And serious adverse events occurred in 44.9% of patients in the Nubeqa group and 42.3% of patients in the placebo group. Adverse events leading to discontinuation of study medication occurred in 13.7% of patients in the Nubeqa group and 10.6% of patients in the placebo group. The breakdown of grade 3-4 AEs is as shown below. Regarding the administration method of triplet therapy, a meta-analysis of 5 phase 3 randomized controlled trials suggested that concurrent administration, including the ARASENS regimen, may be more beneficial than sequential administration. Based on these findings in triplet therapy, maximizing the control of both AR-dependent and independent clones with concomitant use of 3 agents, rather than sequential use, is recommended to delay CRPC and improve survival. So, what I want you to take home is this. Metastatic prostate cancer has a poor prognosis. Prostate cancer is a heterogeneous tumor, and this heterogeneity increases as the disease progresses, contributing to treatment resistance. Cross-resistance between ARSIs and docetaxel has been reported, and comprehensive inhibition of AR signaling has been shown to enhance the sensitivity of prostate cancer cells to taxane-based chemotherapy. Therefore, initiating intensive triplet therapy with 3 agents of different mechanisms of action at an early stage before disease progression may be a rational approach to maximizing treatment efficacy.